Thank you, Dr. Lo. Hi, everyone. Thank you for joining with me in this webinar. If you have any comment, please, or questions, please contact us on LinkedIn or Facebook. And don't forget to subscribe us. Thank you very much. Hi, everyone. I'm Chu. I'm a veterinary pathologist in Taiwan. The topic today I'm going to talk about is diagnosis and treatment of pancreatitis in cats. Most of the information is based on this article in ACVIM consensus statement on pancreatitis in cats. This is the link below for your reference. You can download it for more information. The cat pancreas is a small internal organ located in the abdomen between the kidney, liver, and intestine. Pancreas serves two different functions vital to maintaining health. Inflammation of this organ, which is pancreatitis, can be very serious or even life-threatening if not treated. Pancreatitis has been considered rare in cats, but current evidence suggests that this disease is quite common, similar to the situation in both humans and dogs. In a study of nearly 100 cats undergoing necropsy at the university, the overall histopathologic prevalence of pancreatitis was 66%, with 50% of cats having evidence of chronic pancreatitis alone, and 6% having evidence of acute pancreatitis alone, and nearly 10% have evidence of both acute and chronic. Also, there are 45% of healthy cats that have evidence of pancreatitis. This finding raises the question as to whether there is a population of cats with clinical pancreatitis, or whether the current histopathologic definition of pancreatitis leads to overdiagnosis and needs clarification. Management of pancreatitis in cats remains challenging, and definitive treatments are currently unavailable. In general, acute pancreatitis is characterized by inflammation that is completely reversible after removal of the cause, whereas chronic pancreatitis results in irreversible changes. The differences between acute and chronic pancreatitis are mainly histopathologic and not necessarily clinical. So it may be impossible clinically to distinguish an exacerbation of chronic pancreatitis from an episode of acute pancreatitis. Both acute and chronic pancreatitis can be mild or severe, but chronic cases are more commonly mild and acute cases are more commonly severe. Clinically, mild pancreatitis is associated with few systemic complications and generally a low mortality, although morbidity may be impacted by concurrent diseases. In contrast, clinically severe pancreatitis is characterized by extensive pancreatic necrosis, multiple organ involvement or failure, and usually carry a poor prognosis. There's no age, sex, or breed predisposition in cat pancreatitis. Although pancreatitis has been observed in cats with various infections, including certain parasites and viruses, these infections are rare causes of pancreatitis in cats. Intraoperative manipulation of pancreas and pancreatic biopsy have been suggested as risk factors for the development of pancreatitis. Hypertension associated with anesthesia may be more important than the manipulation. Neoplasia involving the pancreas has been associated with pancreatitis, but is not diagnosed commonly. Pancreatic trauma after road accidents or falling from high buildings, potentially resulting in pancreatic ischemia, has been has been established as a cause. Other rare causes including pharmaceutical compound, autoimmune disease, hypercalcemia, and snake bites. Pancreatitis in cats has been associated with several concurrent diseases, including diabetes mellitus, chronic enteropathies, hepatic lipidosis, cholangitis, nephritis, and IMHA. Most of the cases in pancreatitis in cats are considered to be idiopathic, and a specific cause cannot be identified in most of the cases. The pathophysiology. Premature activation of pancreatic digestive enzymes within axonal cells, leading to activation of other zymogens and resulting in pancreatic autodigestion, is assumed to play an important role in the pathogenesis of pancreatitis in both humans and cats. Hypotheses for the spontaneous development of pancreatitis include autoactivation of cantonic, activation of zymogens by thrombin during bacterial toxemia, ischemia, or hypoxia, co-localization of lysosome proteases and zymogen granules, activation of trypsinogen by capsin B, and enterokinase entering the portal circulation after meal in the congestion of biliary pancreatic reflux, which may cause zymogen activation. Hypoperfusion and thrombosis may also serve as triggers for the development of peripancreatic necrosis. The unique anatomy of cats with shared entry of common bile duct and the pancreatic duct into the duodenum may explain the association between acute cholangitis or bacterial cholecystitis and pancreatitis. High concentration of bile acids or trypsin within the pancreatic circulation may contribute to the development of necrosis. The image upper here is the mechanism that protects the pancreas from premature activation of zymogens. And the image lower here is events that lead to acute pancreatitis due to premature activation of trypsinogen, including biliary pancreatic reflux, or bacterial toxemia, ischemia, or hypoxia. And here's the local and systemic inflammation ensues in acute pancreatitis, which is independent of trypsin activation, but depend on ongoing stimulation of the NF-kappa B pathway. And here's the pathophysiological mechanisms relevant for chronic pancreatitis that occurred independently of trypsin activation and acute pancreatitis. Clinical signs and physical examination findings associated with both acute and chronic pancreatitis in cats are non-specific. The presenting signs in each case help to characterize the severity of the disease. The common clinical signs including lethargy, anorexia, vomiting, weight loss, diarrhea, dehydration, icterus, or fever. Diagnostic imaging. First one is radiography. Abdominal radiography is neither sensitive nor specific for the diagnosis of pancreatitis in cats. The left lobe of pancreas occasionally can be identified on the ventral dorsal radiographs in cats with pancreatitis. Radiographic signs of severe pancreatitis in cats include loss of peritoneal detail in the cranial abdomen or a mass effect. Ultrasonography. Ultrasonography remains the most routine diagnostic imaging tool for cats suspected of having pancreatitis. It should be considered part of the minimum database in these patients. The normal pancreas is echoic or hypoechoic compared to the surrounding mesentery, and is similar in echogenicity to the liver. So you can compare with the liver. Sonography findings in acute pancreatitis in cats may be equivocal or may include pancreatic enlargement, a hyperechoic surrounding mesentery, and focal abdominal effusion. The duodenum may be distended. Ultrasonographic features of chronic pancreatitis are not well established in cats. Findings may include hyperechoic or mixed echoic pancreas, a dilated common bile duct, enlarged pancreas, and irregular pancreatic margins could be observed. Most of the overlap between these features and those of acute pancreatitis. Ultrasonography is a poor diagnostic tool for assessing the chronicity. And here we can see the imaging at left is sagittal plane of abdominal ultrasound imagery of the left pancreatic lobe in a cat with acute pancreatitis. Here we can see the left here. The left lobe of the pancreas is enlarged, diffusely hypoechoic, and surrounded by a halo of hyperechoic mesentery here. And the image at left is sagittal plane of the left pancreatic lobe of a cat with chronic pancreatitis. We can see the pancreas, inflamed pancreas here. The pancreas is mildly enlarged. The parenchyma is diffusely heterogeneous and has a malted echo texture here. The surrounding mesentery is unremarkable. General clinical pathology. A CBC biochemistry profile and urinalysis are part of the minimum database obtained for evaluation of any patient. Although these tests are not specific for the diagnosis of either acute or chronic pancreatitis in cats, they are helpful in eliminating other differential diagnoses and assessing the patient for complications. In cats with acute pancreatitis, indicators of erythrocyte mass may be increased. An inflammatory leukogram, like neutrophilia with left sheet or neutropenia, may be present, usually with acute pancreatitis. In severe cases, evidence for hypocoagulability with DIC may be present, as evidenced by prolonged clotting times, often occurring concurrently with thrombocytopenia. Changes on routine serum or plasma biochemical profile also are variable and unpredictable. Hepatic enzymes concentrations may be increased because of concurrent inflammation of the biliary tree, extrahepatic biliary obstruction, hepatic lipidosis, or some combination of these. Serum creatinine, BUN, as DMA concentrations may be increased as a result of dehydration. In cats with severe acute pancreatitis, azotemia, and low urine specific gravity may result from AKI secondary to hypoxemia, impaired renal microcirculation, or hypovolemia. Azotemia has been linked to the progression of the disease. Hypoglycemia and hyperglycemia can be seen with acute necrotizing and suppurative pancreatitis. And hypoglycemia has been associated with poor outcome. In cats, hypertriglyceride is rare and no association of hyperglyceridemia with pancreatitis has been reported. Changes in the electrolyte concentrations are variable. particularly depending on the dehydration status of the patient. But hypokalemia, hypokalemia, hyponatremia, and hypocalcemia are the most common electrolyte abnormal in cats with severe acute pancreatitis. Lipase. Management of any pancreatic enzymes or damage could be used as a diagnostic marker for cell damage and pancreatitis. However, some enzymes are very small or are scavenged by inhibitors or both, and are rapidly cleared from the bloodstream. The source of other enzymes is not limited to pancreatic cells. So an ideal marker for pancreatitis would be one that is synthesized only by acinar cells and not cleared immediately from the vascular space. So pancreatic lipase fulfills this criteria, but to be useful as a biomarker, the molecule must be measured using an assay specific for pancreatic lipase, which may be a problem. Pancreatic lipase immunoreactivity. Congratulations for the management of FPLI. Most of the data suggests that the management of FPLI is highly specific for the management of pancreatic lipase, and it also is sensitive for the diagnosis of pancreatitis. It should be noted that sensitivity is higher for severe cases than for mild cases. One study reported a positive predictive value of 90% and negative predictive value was 76% for FPL in 206 sick cats. A positive FPL result indicated pancreatitis as a probable diagnosis, but the test cannot be used to rule out pancreatitis. In cytology, cytology allows for a close examination of a focal area of aspiration, but an individual aspirates may not be representative of the tissue as a whole. Here we can see that is the cytology of the acute pancreatitis. There are multiple cohesive clusters of slightly hyperplastic pancreatic exocrine cells, which is characterized by increased cytoplasmic basophilia here. And the background contains blood, erythrocytes here, and inflammatory cells here. Neutrophils, increased numbers of neutrophils were observed with macrophages. In both acute and chronic pancreatitis, the absence of inflammatory cells should not preclude a clinical diagnosis of pancreatitis. Because inflammatory infiltration can be highly localized, especially with chronic diseases. The collection of pancreatic biopsy specimens in cats, surgical or laparoscopic biopsy procedures have been shown to have a low risk for complications. When evaluating tissue biopsy specimens from cats with suspected pancreatitis, the accuracy of histological diagnosis can be limited by the multifocal distribution of lesions in cats with both acute and chronic pancreatitis. Multiple biopsies are recommended, and pancreatitis should not be excluded based on negative biopsy result alone. Cross lesion. In acute pancreatitis, we can see pancreatic fat necrosis, focal peritonitis, hemorrhages, edema, congestion, fibrin that pass from the pancreatic surface through the omentum, mesentery, or the liver. Gross lesion of chronic pancreatitis often are more subtle, but in severe cases, the pancreas may be small with a firm gray multinodular appearance. Adhesions to the small intestine may be observed. There might be not obvious gross lesion observed with pancreatitis. In acute Here's the lesion that's mentioned before in a chronic. Decreased size of pancreas and multinodular gray discoloration could be observed. And here's pictures of acute pancreatitis. We can see that is the duodenum and the pancreas here. We can see that the pancreas is increased in size, edema, and hemorrhages here in the pancreas and the fat here. In the next image here, like this is the pancreas here and the duodenum here, and arrows indicated the fat necrosis here. Okay. These two images are chronic pancreatitis. We can see that the pancreas are mildly enlarged, and mildly we can see that there are multinodular appearance here. And in this image, we can see that the pancreas is here, which is decreased in size and with multinodular appearance, which indicated fibrosis change. In pathology, histological classification and interpretation is important. Interpretation of pancreatic biopsy specimens should include the evaluation of inflammatory cell infiltrates, as well as their spatial distribution, include intralobular or interlobular, and the presence of edema, necrosis, fibrosis, amyloid, cystic acina degeneration, or atrophy. Okay, this system can be used for routine diagnostic pathology and may advance the understanding of pancreatitis in cats. The histopathology report should specify whether pancreatitis is acute, chronic, active, or chronic. Here we can see there are some lesions listed here, including inflammation, edema, fat necrosis, fibrosis, cystic degeneration, and these are the score from 0 to 3. And here we can assess the severity from mild to moderate or severe. In acute pancreatitis, one study divided acute pancreatitis in cats into two forms. Acute necrotizing pancreatitis with substantial necrosis, and acute suppurative pancreatitis where necrosis is not a feature. And we can see that is acute pancreatitis in histopathology. There are some edema, hemorrhages, and inflammatory cell infiltration. Here we can see the pancreatic lobe is still observed in the section. In chronic pancreatitis in cats is characterized histologically by lymphocytic or lymphoplasmacytic inflammation, fibrosis, or atrophy. Can be extensive throughout the interlobular septa or extends into the lobule in severe cases. Extensive fibrosis also may be present, leading to localized stenosis and cyst formation, with squamous metaplasia of the ductal epithelium. Pancreatic neoplasia also can be associated with chronic pancreatitis. And here we can see that this is the histopathology of chronic pancreatitis. We can see that the nodular appearance here, and there are abundant inflammatory cells, fibrous tissue infiltrate between these nodular structures. Okay, let's go to the management of acute pancreatitis. Whenever possible, the cause of acute pancreatitis should be removed or treated, but doing so may be difficult because most cases of pancreatitis are idiopathic. So management is predominantly supportive, and symptomatic. Management of complications and diagnosis and treatment of comorbidities play an important part in successful management. Several diseases and risk factors have been associated with pancreatitis, most of which allow specific treatment. Some infectious agents that cause systemic diseases, which may include pancreatitis, such as toxoplasma, or other that rarely cause pancreatitis, such as these two pathogens, are amenable to treatment. However, because such cases are rare, generally there is no need to test for these organisms. A careful drug history should be taken, and those drugs implicated in causing pancreatitis in cats or other species should be avoided if possible. Fluid therapy. Intravenous crystalloid fluid is administered to correct dehydration and electrolyte imbalances. In addition to the adverse effects of hypovolemia, the pancreas also is susceptible to altered blood flow as a result of increased vascular permeability and microthrombin formation. Establishing normal volemia using early IV fluid therapy may limit tissue damage by improving pancreatic perfusion and oxygen delivery. Dehydration, inaptance, vomiting, and diarrhea can lead to hypoperfusion, resulting in metabolic acidosis and pre-renal azotemia, which can be corrected by fluid therapy. Concurrent hypoglycemia, diabetic ketoacidosis, and kidney disease may further contribute to metabolic acidosis. Further study is needed to determine the ideal fluid choice for the treatment of pancreatitis in cats, but lactated ringers or similar solution often is the first choice. Antiemetics and gastrointestinal prokinetics. Antiemetics are important to minimize fluid and electrolyte losses and to decrease the potential for regurgitation and secondary esophagitis. The most commonly used antiemetic in cats is maropitant citrate. It's a neurokinin 1 receptor antagonist. Maropitant may have additional benefits such as visceral analgesia and anti-inflammatory activity. Ondansetron is a selective serotonin receptor antagonist, can be used as primary or addictive antiemetic. Because maropitant and ondansetron work by different mechanisms, these two drugs can be used in combination if required. Metoclopramide has questionable central antiemetic effects in cats, but when used as a CRI, metoclopramide increased gastric emptying and decreased gastric anatomy. Cisapride is an effective PO prokinase in cats and is a treatment of choice for delayed gastric emptying. Erythromycin also has been shown to have a gastric prokinetic effect in cats. This is the summary table of commonly used fluid therapy and antiemetics in cat pancreatitis. The dosage are listed in the right column for your reference here. The common use fluid therapy and antiemetic therapy, including maropitant and densetron. Here are listed here. In pain management, and pain is difficult to evaluate in cats clinically, especially in the clinic. The cats are usually nervous, so it's hard to evaluate the pain. Opioids should be used as a primary analgesic for cats with acute pancreatitis. Buprenorphine is adequate for most patients, whereas methadone or fentanyl are good analgesic choices for cats with more severe pain. Oral buprenorphine or maropitant can be used for analgesia in outpatients. In addition, tramadol and gabapentin or combination of these two drugs can be considered as PO analgesic options. In appetite stimulants, restoring food intake is an important factor in recovery in most patients. The most commonly prescribed appetite stimulants in cats are mirtazapine and capromorelin. Mirtazapine has been evaluated in aptant cats. Mirtazapine transdermal ointment can be used in cats and generally is well tolerated and efficacious. The safety and efficacy of capromorelin solution is an appetite stimulant and have been reported in healthy and sick cats. Nutrition. Early nutrition support is important in the treatment. Studies have shown that the earlier a cat gets back to eating, the better the prognosis for a good recovery. In patients with severe acute pancreatitis, early enteral nutrition is viewed as an active therapeutic intervention and minimize infected pancreatic necrosis and decrease the incidence of multiple organ failure, thus improving the outcome and the prognosis. When inaptent or prevented from eating, patients will develop hepatic lipidosis, which will substantially increase mortality. Cats with mild to moderate acute pancreatitis often begin to eat with appropriate supportive and symptomatic care. In severe cases with complications, often will require a feeding tube for appropriate alimentation. Lack of enteral nutrition may lead to impaired gastrointestinal motility. Intestinal villi may atrophy, compromised intestinal blood flow, altered barrier function, and the disruption of normal intestinal microbiota. The feeding tube can be used for hydration, administration of medicine, and for gastric decompression. Highly digestible diets, often labeled as gastrointestinal diets, are highly recommended. Placement of an enteral feeding tube is indicated for cats that fail to respond to appetite stimulants within 48 hours, or those have a history of more prolonged anorexia before presentation. Nasal-esophageal tubes or esophagostomy tubes are the most commonly placed tubes in cats with acute pancreatitis. With nasal-esophageal tubes, feeding is limited to a liquid diet because the diameter of the tube is small. Placement of esophagostomy tubes requires general anesthesia and more technical expertise. I forgot to mention that the nasopharyngeal tubes that usually only needs moderate sedation. The esophagostomy tubes is an excellent option when long-term feeding is anticipated. And the esophagostomy tubes allows for feeding of canned diets. And here we can see the picture at the left is the nasal esophageal tube here. There are some shooters here. So you can put the medicine or the food on here. And the picture at the right is esophagostomy tube here, located here. And we can see the diameter of the tube is large. That's in which enteral feeding is not an option because of unmanageable vomiting. Protein alimentation can be provided by PPN or TPN. It's partial parental nutrition and total parental nutrition. However, survival rates for cats receiving partial parental nutrition exclusively are lower than in cats receiving supplemental enteral nutrition. In advanced fluid therapy, fluid, electrolyte, and acid-base imbalances must be assessed and corrected as early as possible. In addition to correction of dehydration and maintenance fluid support with crystalloids, colloid therapy is beneficial when indicated to maintain and support colloid osmotic pressure and to prevent fluid imbalance and edema formation. In cats receiving aggressive fluid support, it is important to avoid volume overload by monitoring respiratory rate and effort, performing pulmonary auscultation, and measuring central venous pressure. Patients that are hypotensive despite crystalloid and colloid fluid therapy may require vasopressor support. And dopamine is a vasopressor that also may increase pancreatic blood flow and decrease microvascular permeability. In persistently hypotensive cats, additional vasopressors should be considered, including norepinephrine, vasopressin, and epinephrine. Antibiotics. Antibiotics are not recommended for non-complicated cases of pancreatitis. Broad-spectrum antibiotics should be reserved for cats with acute pancreatitis in which pancreatic infection is suspected or confirmed. Infection has extended the common pancreatic or bile duct, or CBC findings are suggestive of sepsis. The localization and the type of intrapancreatic bacteria suggest translocation of enterobacteria as a likely source. Corticosteroids. Corticosteroids are not used routinely for the treatment of acute pancreatitis in humans, dogs, or cats. Corticosteroids have broad anti-inflammatory effects and research suggests that they play a key role in enhancing apoptosis and increasing production of pancreatitis-associated protein, which exerts a protective effect against pancreatic inflammation.